Hello, good afternoon. This is Professor Triple N or Nick PA. I would like to introduce you my Pediatrics PA/MP board review notes. And I have a website which is called questmdcenter.com. If you want to contact me, my phone number is 917-388-7644 or via email. The email is nickmd1@gmail.com. Let's start from the first slide. The first slide outlines the infant and childhood development of certain ages. For gross motor, for 3 months, we have a head control. 4 months, the child roll over. 6 months, sits independently. 9 months, crawls. 12 months, walks. 18 months, climbs stairs or runs. And 24 months, kickball. The most important here to remember is for gross motor is months 4, 6, 9, and 12. So 4, 6, 9, and 12. We need to remember that 4 months the child roll over, 6 months sits independently, 9 months crawls, 12 months walks. Let's go to the next slide. Next slide is language. We can see here that on 2 months the child coos, 6 months bubbles, 12 months mama and dada, 18 months 4 to 20 words, and 24 months climbing, combining words, 50% of it's comprehensive. Here to remember, the most important is that 6 months the child bubbles, 12 months it says mama and dada, 24 months combining words, which is 50% comprehensive. Next is continue the language. And this slide outlines the percentage of comprehensibility for different ages. So we said that age of on previous slide, on 1 year, child has 50% comprehensive words. At age of 3 years, 75% comprehensive. 4 years is 100% comprehensible. The age of 7 to 8, the child has a speech, language, and articulation close to adult. Let's go to the next slide. This slide outlines the social and fine motor for different ages. 3 months, the child laughs. 6 months, reaches and feeds self. 9 months indicates what they want and pincer and grabs. At 12 months old, the child imitates and follows one-step commands. Here the most important to remember that at 6 months patients, the child reaches and feeds self. Let's go to the next slide. Continue the social and fine motor information for the social and fine motor. At age of 18 months, the patient scrabbles, feeds self with spoon, brushes, stacks 3 to 4 blocks, and potty train. At 24 months, it follows 2-step commands, wash and dry hands, and 3 years old, dresses with supervision. The most important here to remember that at 18 months, the child scrabbles, feeds self with spoon and brushes. We're talking for newborn and infant growth. Number one, the most important point is number one, newborns may lose up to 10% of their birth weight in the first week of life. Number two, most regain birth weight about 10 days. Number three, first 6 months gain about 1 ounce per day. At 6 months, the weight is twice than the birth weight, and at 12 months, the weight is 3 times the birth weight. Height is 1.5 by the birth length. Here, the most important to remember is that the newborns may lose 10% of their birth weight in the first week of life. Most regain birth weight about 10 days. At 6 months, the weight is 2 times the birth weight. At 12 months, the weight is 3 times the birth weight, and height is 1.5 per birth length. Childhood growth. After 2 years of age, the patient puts 2 to 3 kg and 5 to 7 centimeters per year. Number two, average 30 months weighs 30 pounds and is 30 inches tall. Number three, average 4 years old, weighs 40 pounds and is 4 inches tall. And number four, weight loss in a child is always suspicious. Let's go to the next slide. Number 9. Abnormal growth. We'll talk here about failure to thrive and short stature. Let's go to the next. FTQ, or failure to thrive. By definition, the weight that decreases below the 3rd or 5th percentile, or weight loss that crosses 2 major percentiles, that causes a inadequate caloric intake, which is puberty, feeding problems, inadequate nutritional knowledge, GERD, neglect, abuse, and potential mental health. Number two, inadequate calorie absorption means that vomiting from the metabolic disorders, food insensitivity or malabsorption from celiac disease, cystic fibrosis. And number 3, it's excessive caloric expenditure, which is chronic conditions, congenital heart diseases, chronic pulmonary diseases, and hyperthyroidism. Let's go to slide number 8. We need to do an initial evaluation, which includes number 1, history. We need to identify the cause of in a majority in the cases, such as feeding patterns, vomiting, bowel habits, social, emotional, and financial stability and development. On a physical exam, number 2, we need to focus on the signs of organic disease, evidence of abuse and neglect, dysmorphic feature, skin lesion, heart murmur, abnormal masses, neurology exam. Number 3, on the labs, we need to do is CBC, BUN, creatinine, electrolytes, UA, culture and sensitivity, and thyroid studies. For the treatment of failure to thrive, we need to first identify the underlying cause. Then we need to give a high-calorie diet, proper education, frequent monitoring. If severe, fail output management, severe malnutrition, evidence of abuse and neglect, psychosocial impairment of caregiver, all these require hospitalization and then social services. Let's go to the next slide. Slide number 12. In growth disturbances, we have to distinguish between normal and abnormal conditions. 2 for evaluation, that's growth curves, which is a critical factor in evaluation. Number 2, we need to target the height. It's helpful to evaluate growth potential for boys. Means the mother's height in centimeters plus 13 plus the father's height in centimeters divided by 2. For girls, mother's in height in centimeters plus father height in centimeter minus 13 divided by 2. We need to also evaluate bone age and to measure for skeletal maturation. Let's go to the next slide. Let's talk about short stature. There are 3 things which are very important here. Familiar short stature. Number 2, constitutional growth delay. Number 3, chronic condition. Let's go to slide number 14. Normal variants, we have number 1, familiar short stature. This is when the normal birth size, we have deceleration of growth curves, first 2 years of life, normal bone age and puberty, and the target height is short. For a constitutional growth delay, we have a normal birth size, growth pattern familiar to familiar short stature, delayed bone age and puberty, and so-called late bloomers, which the target height is normal. For chronic conditions, we need to discuss is number 1, endocrine conditions, which is GH deficiency, hypothyroidism, Cushing syndrome and disease. Number 2, this could be a nutritional issues. Number 3, systemic disease like GI, renal, cardiac, pulmonary, and immunology. And number 4, genetic syndromes such as Turner, Prader-Willi, and Down syndrome. Let's discuss pediatric ENT, which includes upper respiratory infection, acute otitis media, chronic otitis media, otitis externa, croup, amblyopia, and ENT foreign body. On slide 17, we have viral URI, which are common in any age group, especially infants and toddlers. They last 7 to 10 days. Main common cause is rhinovirus. Symptoms present with runny nose, nasal congestion, coryza, sneezing, mild conjunctivitis, sore throat, hoarseness, cough. The fever is often presented in the first 2 to 3 days, and the treatment is cough and cold medication for age over 2, no antibiotics necessary. Let's go to the next slide, 18. For otitis media, could be acute otitis media, and this could be 2 types, bacterial and viral. For acute otitis media, this is infection of the middle ear cavity, most prevalent in children between 6 and 24 months. The bacterial causes strep pneumo is the most common. Then number 2 is Haemophilus influenza. Number 3, Moxarella catarrhalis. The viral could be 3 main causes: RSV, rhinovirus, and flu virus. Let's go to the next slide, 19. Which are the risk factors for this clinical condition? This is daycare attendance, formula-fed infants, feeding position very important, secondhand cigarette smoking, how they present and diagnosed, often followed by upper respiratory tract infection or URI by 1 to 7 days, usually presents with fever, poor feeding, pain and irritability, vomiting, ear pulling. The TM, it's bulging, red landmarks are not visualized, immobile. We need to do otoscopy or pneumatic otoscopy with evaluation of movement of TM is the most important. And also we can do is tympanometry. The antibiotics, drug of choice is amoxicillin, 80 to 90 milligrams per kilo per day, microlide erythromycin if allergic. So we give amoxicillin high dose, or if allergy, microlide, which is erythromycin. If treatment fail after 48 hours, we need to give amoxicillin coagulanate or ceftriaxone. Less than 2 years old, generally treated. Over 2 years old, observe. And the treatment if symptoms are severe, what kind of complication we can have. Chronic suppurative otitis media, hearing loss, mastoiditis, post-auricular abscess, facial nerve paralysis, labyrinthitis, meningitis, and brain abscess. For chronic otitis media, the definition is recurring or persistent infection inflammatory for several months, recurrent otitis media or otitis media with infusion, or persistent drainage over 2 weeks. We're talking about chronic suppurative otitis media. The risk factors are multiple ear infections, allergies, trauma, swelling of the adenoids, surgery in case of hearing loss, otorrhea, pressure, or earache. Physical exam, we can see inflammation, air fluid levels, discharge, perforation. Treatment for chronic suppurative otitis media, topical antibiotics like quinolone or aminoglycosides, recurrent otitis media or otitis media with effusion, we need surgery, meningotomy with or without tubes, repair and adenoids. Complications, this is permanent hearing loss, mastoiditis, post-auricular abscess, facial nerve paralysis, labyrinthitis, and meningitis and brain abscess. Next slide is 21. Otitis externa. This is inflammation of the skin of outer ear canal, commonly caused by watery trapped in the canal from swimming in lakes or pools. Pathogens, this is mainly Staph aeruginosa or Pseudomonas aeruginosa. Presents with pain, purulent discharge, pain elicited with traction of the pinna or tragus. Treatment is first line, topical antibiotics drops, with or without corticosteroid, hydrocortisone, and acetic acid, hydrocortisone, polymyxin, B neomycin, second line, quinolone. Let's go to the next slide. Viral group or laryngotracheal bronchitis. The most common cause for stridor in children. Peak age is 6 months to 3 years, usually most frequently fall and winter. Presents with barking cough, URI, hoarseness, fever, inspiratory stridor. The pathogens are parainfluenza virus common. Diagnosis HMP. Season is helpful. Usually in fall, winter is less than 50%. The steeple sign is on the anterior neck X-ray. Treatment first line, steroid, first dose of dexamethasone. Hydration and humidity. Racemic epinephrine is the only choice if it is severe. Let's go to the next 23. Diopia, this is by definition decrease or loss of vision in one or both eyes in absence of ocular and CNS pathology. It is initiated by any condition that result in abnormal and unequal visual input between the critical period at birth to 8 to 9 years of age. Uh, the, the diagnosis is by evaluating visual acuity, for example, strabismus, congenital cataracts, and family history. Treatment is patching, essential within the critical period, otherwise loss may be permanent. Let's go to the next slide. This one patient which has amblyopia. Let's go to the next slide. 25. ENT foreign bodies. That's a common question for the boards. Common C's are buttons, beds, beads, marbles, nuts, toy parts, bugs to ear. In the ear, cause ear pain, drainage, hearing loss. In the nose, unilateral purine rhinitis, persistent sinusitis, blocked nasal passage on exam. And the removal, do not do blind probe, first line, if visual, force exhalation, forceps, curette, 40, inflamed, past the foreign body. Inflated past the foreign body. Mother's kiss. Restraint is essential to prevent further injury. Next slide. One question here, quick clinical question. When treating clinical group, you could reasonably include all of the following except A. IV steroids, B. Intubation, C. Racemic epinephrine, D. Oxygen and cool mist, E. IV ceftriaxone. And the right answer is E. Let's go to the next. Voila, we are right. Let's go to the next question. Next question read, 15 months old male presents with 2 days history of upper respiratory infection, type symptom followed by barking cough and low-grade fever. Which of the following is the most appropriate management on this patient? A. Albuterol, B. Racemic epinephrine, C. Intubation for ventricular support, D. IV antibiotics, E. Dexamethasone, IV, IM, or PO. And the answer here is E. The most appropriate management for this patient is dexamethasone, IVIM, or PO. Voila! Let's go to the next slide. Slide number 30. Another clinical question reads, 15 months old male presents with 2 days history of respiratory infection, type symptoms followed by barking cough and low-grade fever. Which of the following is the most appropriate management in this patient? Number A, serous otitis media. Number B, acute otitis media. C, chronic otitis media. D, external otitis media. E, cholesteatoma. So we have here 8 months male 18 months old, with fever, cough for 3 days. He appear ill, and on exam we have bright red tympanic membrane and green discharge from the nose. The fever is 103, chest X-ray negative. The right answer here is B, acute otitis media. Voila, we reach the point of the lungs. For the pediatric lungs, we'll talk about bronchiolitis, pneumonia, which is viral, bacterial, or atypical. We'll talk about pertussis. We'll talk about acute respiratory distress syndrome, cystic fibrosis, and foreign bodies. Let's go to the next slide. Bronchiolitis, this is the most common lower respiratory illness in infants and young children less than 2 years old. Pathogen is RSV in 50 to 90% of the cases. Symptoms are cough, mild fever, tachypnea, and wheezing. And we have thick nasal congestion. The diagnosis we need to do is RSV antigen nasal wash, chest X-ray, usually hyperinflation. The treatment is controversial. Oxygen for young children, nebulized albuterol community used, oral steroids if symptoms severe, Synagis, which is prevention of RSV in premises. Next is viral pneumonia. The most common is common in all group ages. It's usually followed by URI. Etiology, most common cause for pneumonia in children. This is RSV. Then followed by parainfluenza, influenza viruses. Symptoms, URI, which precede with the onset of cough, wheezing, which is grunting, nasal flaring, they're common. Let's go to the next slide. The labs, WBC could be low, normal, or slightly elevated. The high WBCs makes the viral etiology unlikely. Nasopharyngeal swab to identify. Imaging, the chest X-ray may show peripheral striking, increased interstitial marking, and peribronchial cuffing. Treatment we need to do is supportive care, antiviral if the flu-related severe and within the 48-hour symptoms, oseltamivir. It is rarely possible to differentiate viral from bacterial pneumonia based upon history, exam, labs, or radiography. Therefore, it is common for appropriate concomitant antibiotics coverage to be used for viral pneumonia in children. Next is bacterial. We have here is information of the lungs classified according to the affecting organism and site. Occur in all age groups, but more common in children less than 2 years old. 2 years old. Common pathogens are S. pneumo and group B strep for neonates. S. pneumo, group A strep, and group B strep for neonates. Symptoms: if there is a URI, precede abrupt onset with fever, chills, shortness of breath, anorexia, cough, and dyspnea. We have nausea, vomiting, abdominal, chest, and shoulder pain. It is a typical. Slide 37, we talk about signs of pneumonia, bacterial pneumonia, which is tachypnea frequently, reliable sign of pneumonia for kids, cough, grunting, nasal flaring. Exam usually presents with decreased breath sounds, most important rails, dullness to percussion, but can be normal. Wheezing unusual in bacterial pneumonia unless patient has baseline reactive airway disease. Labs presents with WBC more than 15,000 or greater. Blood cultures are positive in 10 to 50% of the cases. Imaging presents with lobar consolidation. Patching infiltrates are common. May see effusion and atelectasis, vice versa infiltration. Often hard to tell. Treatment is neonate with IV ampicillin and gentamicin, all the ages. First line amoxicillin. And alternative is the second and third generation cephalosporin and microlides. Complication usually is a respiratory failure, sepsis, pulmonary abscess, pleural effusion. Pneumonia is usually atypical, presents with chlamydia pneumonia, usually occurs between 2 weeks and 6 months of age. Peak age is over 90% by 8 weeks. Most common cause of pneumonia in children under 6 months of age, 25 to 45% of the cases. The pathogen is C. trachomatis, which is maternal STD. URI prodrome near 100% upper brow, staccato cough, very important, tachypnea, rales, conjunctivitis. Diagnosis is nasopharyngeal culture, eosinophilia common. Treatment is microlides, erythromycin, hospitalization for those with paroxysmal cough, apnea, and respiratory distress. Let's go to the next slide, slide number 40. Mycoplasma pneumonia or atypical pneumonia is common in age of 5, especially in teens. Pathogen is Mycoplasma pneumonia, long incubation 2 to 3 weeks. Symptoms are gradual onset, dry cough, progressing to productive fever, headache, malaise. Signs are rales, Bullous Maryngitis, chest X-ray, middle and lower lobe infiltrate. Treatment is microlights. Erythromycin usually shorten course and may lessen severity of the symptoms. Pertussis, which is whooping cough, presents in infants, toddlers, and partially immunized. The pathogen is Bordetella pertussis. It spreads by teens and adults which are no longer immune. Symptoms: there is 3 stages: catarrhal URI 1 or 2 weeks, paroxysmal staccato cough or whoop on inspiration 1 to 2 weeks, and convalescent dry cough 1 to 2 weeks. Diagnosis is based on the history, characteristic paroxysmal cough. Gold standard is the nasopharyngeal culture, PCR, and the treatment is microlight erythromycin. Let's discuss so-called acute respiratory distress syndrome. The cause for this is deficiency of surfactant. Let's go to the next slide, slide number 42. A risk factor is usually prematurity, signs and symptoms. We have increased respiratory rate, cyanosis, and expiratory grunting. The diagnosis: chest X-ray shows hypoexpansion, bilateral atelectasis, ground gas, or air bronchograms. Treatment is oxygen, CCAP, early intubation, ventilation, and surfactant replacement. Let's go to the next slide, 43. Cystic fibrosis is the most common severe inherited disease in the Caucasian population, 1 to 2,500. Respiratory symptoms: chronic cough or sinusitis, recurrent pneumonia, nasal polyps, clubbing. GI symptoms: presents meconium ileus 20%, pancreatic insufficiency 85%, failure to thrive. Diagnosis: we have sweat chloride is the gold standard, over 60 milli equivalent per liter is abnormal. And we have genetic testing. Treatment is antibiotics, pancreatic enzyme, bronchodilator, and postural drainage. Mean survival age is increased. We have a respiratory foreign body. Could be in the throat, which cause stridor, choking, cyanosis. Can occur if foreign body is in esophagus. We have bowel valve effect, may cause hyperinflation. Heimlich maneuver if suspected. We suspect upper air foreign body and respiratory distress. Rigid bronchoscopy if in lower air. Let's start again from cardiology. we will talk about acquired heart diseases. In this case, the most important is rheumatic fever. Usually in this, we have functional murmurs like Still's murmur, venous hum, or congenital heart diseases, which are two groups, cyanotic and acyanotic lesions. In slide 46, we talk about rheumatic fever, which is an inflammatory disease triggered by group A strep and can cause permanent damage of the heart muscle and the valves, affects ages of 5 to 15 years old. There is so-called Jones criteria, which are two types. Major, which includes carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules, and minor, which includes fever, arthralgia, elevated ESR and C-reactive protein, prolonged PR interval on EKG. For the diagnosis of rheumatic fever, we need two major criteria or one major and two minor. The treatment is first line of treatment. This is penicillin VK, bed rest, salicylate, steroids for severe carditis, chlorpromazine or haloperidol for chorea. Prevention is by preventing the recurrences. First line is penicillin benzoate every month. Let's go to the next slide. Next slide is 47. We have here we discussed two types of murmurs, Still murmur and venous hum. Still murmur, this is the most common innocent murmur in childhood, usually ages of 2 years to adolescent. The loudest apex is the left sternal border. This is a musical or vibratory, high-pitched first to third degree early systolic, which murmur which diminish with sitting and standing position and Valsalva maneuver. Then the second one is venous hum. This is very common after age of 3 years old, produced by turbulence in subclavian and jugular veins. This is continuous musical 1 to 2 in the upper right, left sternal and lower neck disappear if supine or jugular veins compression. Let's go to the next slide. This slide we talk about cyanotic lesions. Let's start with arterioseptal defect. And the most common arterioseptal defect is type 2 arterioseptal defect. Now we will mention also VSD or ventriculoseptal defect. This is the most common form of congenital heart disease. Occurs in about 2 per 1,000 live births and presents with loud whole systolic murmur along the left sternal border. Also we can talk here about patient PDA or patient ductus arteriosus, coarctation of aorta, which is when we see a blood pressure in the upper extremity 20 or greater than the lower extremity. Arterial septal defect, this is the next slide, 49. ASD, this is the communication between the right and left atria. Children are frequently asymptomatic. S2 is widely split and fixed, and treatment is surgical repair. Let's go to the next slide, which is VSD, slide number 50. This is the most common congenital heart disease. Presents as a communication between left and right ventricles. Also, there is a small VSD, which is asymptomatic, and large VSD, which presents at week 4 to 6 weeks in the congenital heart failure. It presents with congenital heart failure. Presents with loud, harsh, whole systolic murmur along the left lower sternal border. Treatment is to control the CHF, surgery if unresponsive to medications. The next slide, 51. Patient patent ductus arteriosus, which presents in the fetal life, allowing the blood from the pulmonary artery to flow in the aorta, bypassing the non-aerated fetal lungs. Usually closes spontaneously by age 3 to 5 days of life. Risk factors: prematurity, female maternal rubeola. Surgery mostly asymptomatic. Can have, no, this is symptoms, mostly are asymptomatic. Can have machinery murmur, which is continuous and maximal at the second intercostal space, bounding peripheral pulses and wide pulse pressure. Treatment is usually medical with indomethacin in preemies, cardiac catheterization in full-term infants, and may require surgical correction. Let's go to the next slide. Let's discuss coarctation of aorta. This is narrowing of the aortic lumen, more common in males. Symptoms: presents with symptoms of CHF and hypertension. Diagnosis is when the pulses are greater in the upper extremity. 2, when the BP of the upper extremity is more than lower extremity by 20 millimeter of mercury. And number 3, presents with the blowing systolic murmur in the left axilla. On X-ray, we can see notching of the ribs in older kids, and the treatment is surgical correction. Let's go to the next slide. Slide number 53. Here we talk about transposition of the great vessels. Then tetralogy of Fallot, which presents with VSD, pulmonary stenosis, overriding of the aorta, and right ventricle hypertrophy. Next slide. 54. For transposition of the great vessel, we have abnormal arrangement of the great vessels. Pulmonary artery connects to the left ventricle and aorta connects with the right ventricle. Symptoms are cyanosis, shortness of breath, decreased appetite, poor weight gain. The treatment is surgical. Next slide, 55. Let's talk about tetralogy of Fallot. This is the most common type of cyanotic heart lesion. There is 4 components: VSD, pulmonary stenosis, overriding of aorta, and right ventricular hypertrophy. We have sudden cyanosis, dyspnea on exertion, which presents with hypoxemic spells, aka TET spells. Also, we can hear a rough systolic ejection murmur in the third intercostal space. X-ray presents with boot-shaped heart, and treatment is medical. Then, if it doesn't work, surgical by 18 months of age. Here we can see on slide 56 the normal heart on the left side, and on the right side is tetralogy of Fallot, which presents, as we said, overriding the aorta, pulmonary stenosis, ventricular septal defect, and a right ventricular hypertrophy. Let's do a couple of questions. We have here a scenario of 2 years old. This is slide 57. 2 years old is brought to emergency room by the mother with sudden onset of choking, gagging, coughing, and wheezing. Vital signs of temp of 37, pulse 120, respiration 28. On physical exam, reveals decreased breath sounds over the right lower lobe with inspiratory rhonchi and localized inspiratory wheezing. Chest X-ray review normal inspiratory views, but expiration view shows localized hyperinflation with mediastinal shift to the left. Which of the following is the most likely diagnosis? Number 1, asthma. Number 2, epiglottitis. Number 3, foreign body inspiration. Number 4, pulmonary embolism. And number 5, viral pneumonia. Let's think about a few minutes. Here we have a typical presentation of the right answer is 3, foreign body aspiration. We have the age, the symptoms, the physical exam, and the chest X-ray, which shows that the right answer here is foreign body aspiration. C is the right answer. Let's go to the next. We have slide 59. 6 months old comes to your office during the winter looking mildly ill with fever of 100.7, RRR of 72. He has wheezing throughout his chest, scarred rails and rhonchi. Your working diagnosis is number 1, failure. Number 2, bronchiolitis. Number 3, croup. Number 4, epiglottitis. Number 5, pneumonia. Here we have 6 months old, which presents with fever and tachypnea. And on physical exam, we have wheezing throughout his chest and here and there rails and rhonchi. The most suitable diagnosis, this is B. Let's go to the next question, slide 61. 61, we have scenario of 18 months old, which is documented that less than 10 percentile of your growth chart is having trouble breathing. He has a history of intermittent dyspnea and chronic cough since birth. Post-delivery, patient did not defecate for quite some time. Which of the following diagnosis tests will be most useful for this child evaluation? Number 1, rectal biopsy. Number 2, chest X-ray. Number 3, urine glucose assessment. Number 4, urine protein assessment. And number 5, sweat test. So if we see here that the patient is 18 months old, you have trouble breathing, also chronic cough, and it is underweight, and also post-delivery, patient did not defecate for quite some time. So if we summarize all these buzzwords, it leads us that patient has the best test to evaluate is sweat test, and the patient has a cystic fibrosis. Let's go to the next slide. Slide number 64. Which of the following congenital defects is associated with cyanosis? Number 1, patent ductus arteriosus. Number 2, ASD. Number 3, VSD. Number 4, coarctation of aorta. Number 5, tetralogy of Fallot. If we review all the answers and exclude few of them, we'll see that here the best answer is 5, tetralogy of Fallot is the right answer. Slide 66, we have a section to review for GI and nutrition of pediatrics. We'll talk about appendicitis, pyloric stenosis, intussusception, PKU or phenylketonuria, and GI in foreign bodies. Let's go to the next slide. Let's talk about appendicitis first. This is slide 67. Appendicitis presents usually with acute onset periumbilical pain which spreads to the right lower quadrant, worsening with movement, abdominal pain before other symptoms. Also there is nausea, vomiting, low-grade fever, and abdominal swelling. The risk factors are age of 10 to 30 years old. Diagnosis is done by ultrasound or CT scan. Treatment is surgery, and the complication is rupture. Let's go to the next slide. 68. Pyloric stenosis. This is slide 68. In pyloric stenosis, we have hypertrophy of the muscular layer, the pylorus, which leads to obstruction. Begins between age of 2 to 4 weeks, rare at birth or over age of 6 months. Much more common in males. The classical presentation is projectile, non-bilious vomiting, and palpable pyloric mass or olive. Hungry child. Diagnosis is with physical exam and ultrasound. Treatment is surgery. Let's go to the next slide, 69. We have here discussion for intussusception. This is invagination of part of the bowel into the adjacent part of the bowel. Most cases is idiopathic, male more frequent than female. Most commonly from age 6 to 12 months of age. Symptoms are usually paroxysmal abdominal pain is the main symptom, followed by diarrhea and vomiting. Also, we can see so-called current jelly stool in 50% of the cases. Exam presents with sausage-shaped mass. The treatment is a reduction by barium enema and or open surgery. Next slide, please. PKU or phenylketonuria. Cause for PKU, this is decreased activity of phenylketonuria hydroxylase, which is an enzyme which convert phenylalanine to tyrosine. Signs and symptoms, severe congenital delay, which is the most important, hyperactivity, seizures, light complexion, urine with mousse-like odor. Diagnosis is increased phenylalanine and decreased tyrosine. Treatment, limit dietary phenylalanine. Let's go to the next slide. GI foreign bodies. The most frequent are like coins, toys, and batteries. Could be in the upper esophagus, which is removed to lower the risk of aspiration. Foley catheters are often used. Lower esophagus, it's removed if it is more than 24 hours in the stomach. Usually if they are less than 3 to 5 centimeters, they can pass the GI tract. If the object is sharp and caustic, open safety pin, camera, batteries, would have to do endoscopy. And if it is toxic, like medication tablets, we need to do lavage. Let's go to the next slide. We have here a question of scenario and a question of 12 years old accidentally swallow a broken tap from the aluminum soft drink more than 6 hours ago. She can swallow liquids, but solids can cause discomfort. On X-ray, there is a flat metallic object located in the level of the aortic arch. The question here is, which is the most appropriate cause of action? 1. Admission to surgical extraction. 2. Removal of the tap by endoscopy. 3. Extract with Fogarty catheter. 4. Gastrographin swallow to the right esophageal injury. Number 5. Observation of the patient stool for passaging of the tap. So here we need to note that the level of the foreign body, this is at the level of the aortic arch. And summarizing of whatever we said for GI foreign body, here the right answer is 2, or B, removal of the tap by endoscopy. So here's the right answer, remove the tab by endoscopy. Let's go to the next slide. Which of the following findings are most suggestive for diagnosis of pyloric stenosis in an infant? Number A, epigastric mass. B, failure to thrive. C, projectile vomiting. D, abdominal distension. As we remember, for pyloric stenosis of an infant, failure to thrive is the most common signs and symptoms presentation, so the right answer here is B. Projectile vomiting or C. I apologize for the mistake. Let's go to the next slide. Here, the next slide will review the orthopedic part. We'll talk about crucifixion of fracture, congenital hip dysplasia, SCFE, Osgood Schlatter, and nursemaid elbow. Let's go to the next slide. In this slide 78, we can see the Salteo-Harris classification of different type of fractures in children. Type 1, this is epiphyseal separation throughout the feces. Number 2, fracture through a portion of the feces, but exiting across the metaphysis. Number 3, this is fracture through the feces, but exiting across the epiphysis in the joint. Number 4, the fracture is throughout the metaphysis, physis, and epiphysis. And the crush injury when you have, disarrangement of the feces. So let's go to the next slide. Here we can see Salteo-Harris fracture by types. The most frequently is type 2, and this is in 75% of the cases. So let's do a clinical vignette. Secondary to a traumatic event, a child complained of pain in the index finger. X-ray of the digit demonstrate a fracture through the metaphysis of the proximal aspect of the middle phalanx, ending in the epiphyseal plate. And the question is, what type of fracture does this child have? And the right answer is Salteo-Harris type 2, which is, as we said before, 75% of the cases. Let's go to the next 81. 81, slide 81, discuss so-called congenital hip dysplasia. This is a developmental dislocation of the hip. There is an increased risk in firstborn females, breech birth, and family history of DDH. Diagnosis is by screening exam, essential for each visit. We do ortho-1 test, which is out. We abduct and externally rotate, and we have a palpable click as dislocation is reduced. And we have Barrow test, which is in test. We have abduct and internally rotate, and we have a palpable click as the hip dislocates. On a physical exam, we have asymmetrical thigh folds. Let's go to the next slide. Here we continue discussion for congenital hip dysplasia. We do ultrasounds under the age of 3 months and X-ray if older. The treatment is harness or surgery. Complications are if untreated, patient has limping, pain, DJD of the hip. Let's go to the next slide. Next slide is talking about SCFE, slip capital femoral epiphysis. Here we have the femoral head is slipped and exposing the anterior and superior aspects of the femoral neck. Is usually more in males between age of 14 to 16 and females between age of 11 and 13. It is associated with obesity, increased height, genital underdevelopment, and pituitary hormones. And symptoms are acute and chronic hip and knee pain. The treatment is surgery. On this image, we see the normal hip, and then we have hip with SCFE or slipped capital femoral epiphysis. Let's go to the next slide, 84. Let's talk about so-called Osgood-Schlatter syndrome. This is when we have fibrocartilage microfracture of the patellar ligament. The most common is in adolescent males. Usually activity is related to pain which lasts 12 to 24 hours. There is a tenderness and thickening of the tibial tubercle. X-ray shows acute to soft tissue swelling and blurring edges of patellar tendon, chronic 3 to 4 months, fragmentation, prominence. The treatment is rest, ice, compression, and NSAIDs. The next slide, which is slide 85, we'll talk about nursemaid elbow. We have subluxation of the radial head. It can occur after forearm or wrist is jerked with longitudinal or pronatal forces like airplane. Common presentation is child hold the arm in pronate and flex position and resist extension. Diagnosis is history exam and X-rays, which are usually normal. Treatment, reduction by supination and flexion of the arm, splint if recurrent, and then prevention. Now this slide, we can see this nursemaid elbow graphical presentation. Let's go to the next slide. Slide 86, we have pediatric dermatology, and here we will discuss rashes in case of measles, mumps, rubella, varicella, roseola, erythema infectiosum, hand, foot, mouth disease, Kawasaki syndrome, and we will review the immunization schedule. Let's go to the next slide. Measles or rubella. This is morbidiform virus in a paramyxovirus family. Rare in any age. Incubation period is between 8 and 12 days for symptoms and 14 days for rash. Prodrome usually fever 101, cough, coryza, conjunctivitis, and copic spots. The rash is usually on the neck and abdomen first, and usually maculopapular. Treatment is primary supportive treatment. And next slide, 88. We see this rash, rubella, and measles. Let's go to the next slide. 89, mumps or parotitis. This is paramyxovirus. Incubation period is 12 to 25 days. It's during late in the winter or spring. Presents with pain and sweating in front or up and below ears. Is often in the testicular pain within a week, and usually has a complete recovery with supportive care within 1 to 2 weeks. This is the rule in this case. And we see here in this slide, patient with mumps or parotitis. This slide, which is slide 90, we have rubella or German measles. Rubella virus is a Toga virus or Ruby virus. Rare in any age. Usually congenital rubella is deadly, especially in the first trimester. We have so triad deafness, cataracts, cardiac defects. The description is blueberry muffin baby. It acquired, presents with erythematous rash, progressing from head to toe, and the treatment is usually prevention. And we'll see here from Wikipedia image of this rash. Let's go to the next slide. 91, varicella or chickenpox. This is varicella zoster virus, usually 5 to 9 years old, late in the winter, early spring. Incubation period is 10 to 21 days. Clinical course presents with fever, pruritic rash. Rash starts in the chest, back, or face, then spreads all over. This is usually erythematous papule, vesicles, and scabs. The description is dew drops on a rose petal. Treatment is supportive. Let's see one patient with this type of rash. Slide 92. So the most important here is to remember erythematous papules, vesicles, scabs, or the classical description is dew drops on a rose petal. Let's go to the next slide. Slide 93. We have the same rash. Next slide, 90. Here we talk about roseoa or roseoa infantum. Usually it's caused by virus HHSV 6, ages from 3 months to 4 years. Incubation is 5 to 15 days. Presents with maculopapular rash, high fever 102, 105 for 3 to 5 days. When fever starts resolving, then the rash appears. The treatment is supportive. Let's go to slide 95. We have here erythema infectiosum or fifth disease or slap chick syndrome. This is a parvovirus, usually in school-age children. Incubation is 4 to 14 days. Presents with red facial rash, slap chick, and lashy pink macular rash on torso and extremities. Pregnant women are at risk, which cause hydrops fetalis. The treatment is supportive. The next slide shows one patient with this type of rash. The most important here to remember is that presents with a red facial rash, slap cheek, and lashy pink macular rash on torso and extremity. Okay, let's go next slide. Slide 97, we're almost done. The same here. It's courtesy of Wikipedia. Then we have discussion here for hand, foot, and mouth disease. This is caused by coccidioides virus A16, the most common, under 5 years of age. Incubation is 3 to 7 days. Presents in late summer or fall. The most important here is presents as a painful oral ulcers, low-grade fever, gray to red vesicles on the hands and feet. Treatment is supportive. Differential diagnosis is hemorrhagina or gingival stomatitis. All right, the next slide, which is 99, it shows this type of rash, courtesy of Dr. William Sears. So this is a rash for hand, foot, and mouth disease, which let's go to the rash. The same time with 10, same type of disease, and rash slide. So presents with painful oral ulcers, low-grade fever, great red vesicles on the hand and feet. The last one was reviewing clinical form of pediatric rashes. This is Kawasaki syndrome and disease, which is called also mucocutaneous lymph node syndrome. Usually its etiology is unknown. Infectious agent is likely. Under the age of 5 years old. Presents with fever which is more than 5 days and 4 of the following: conjunctivitis, rash, mucosal changes, edema of the hands and feet, cervical adenopathy more than 1.5 centimeters. Complication usually is coronary artery aneurysms. The treatment is IV, IG, and aspirin. Let's go to the next slide. So let's talk about a recommended childhood immunization schedule for United States. And we'll do a couple of questions related to that. Slide number 104. Which of the following vaccines can prevent cancer? This is hepatitis B vaccine. C. Let's go to the next. We have 6 days ago, clinical vignette, which states that 6 days ago, a 2-year-old boy had a temperature of 40 Celsius or 104 Fahrenheit. No specific cause was found. His fever has persisted and he now has injected conjunctiva, strawberry tongue, dry fish lips, erythema, and desquamation of the hands and feet, and bilateral cervical adenopathy. Which of the following is the most likely complication of this condition? So we have 1, chorea, 2, congenital heart disease, failure, 3, coronary artery aneurysm, 4, mesenteric arteritis, and 5, valvular heart disease. If we analyze this question, we can see that the right answer here is coronary artery aneurysm. So the right answer here is C, 3 or C, coronary artery aneurysm. Let's go to the next slide. Slide 108. In this clinical scenario, we have previously healthy 15-month-old boy becomes anxious and beginning crying and drooling. A few minutes earlier, he had been calmly playing with his toys. Temperature is 37.7, pulse 84, respiration 18. On physical exam, the posterior pharynx is mildly injected, but otherwise clear. The lungs are clear on auscultation and percussion. Findings on chest X-ray are normal. Within an hour, he is calmer, but he continued to drool heavy. Which of the following is the most appropriate next step? 1, administration as syrup of ipecac. 2, barium swallowing X-ray study. 3, chest physical therapy. 4, esophagogastroduodenoscopy. And 5, insertion of GI tube. Here, obviously, we're talking about foreign body aspiration, and the right answer is 4. We have to do is esophagogastroduodenoscopy. This is the end of the lecture. Thank you so much. If you want to reach me, this again, Nick Nicole, PAC, MS. You can reach me at cell phone 917-388-7644 or email nickmd1@gmail.com. Thank you.